We'll start the lecture. I know it's being recorded. So let me try to share my screen, and I always have Diane over there to help me if I make a mistake. Um, I think that's going to be screen two. Can you see my screen?
Yes,
Is it better now, or should I leave it like it was before?
this is good.
This is good. So the topic of our presentation today is dissemination implementation research, and we are focusing on mobile phone-based intervention diabetes self-management education and all the other support interventions. Um, in the lecture that I sent, like I mentioned before, you have um, more technical information, almost like a lecture, what dissemination implementation research is. But I'm going to give you a little bit in the first 20 slides of why we're doing this. And that's the research we've done through this grant that we have, an NIDDK grant. It's a center grant, a P30 with the Washington University. There are four co-PIs, multiple PIs in this grant. Um, Dr. Deborah Harry Joshua from WashU is the leading PI, so to speak, because their university, Washington University, is the one that submit the grant. We have Dr. Kumanika from Drexel University, um, and we have some other colleagues from their American and Asian, uh, American Indians, no Asian American Indians, Indigenous. I forgot what the name of the big association in Washington, and they are focused on, as you may imagine, on disparity issues, as well as the folks in Drexel. And we are supposed to be a core for applied health informatics on the issue of diabetes prevention control. And that's how we produce the first grant on this topic. And that's why I wanted to bring a little bit of back to our presentation. So we've done three research, but initially you had focus on understanding what's the field right now. How is health information technology contributing to diabetes? So we implemented two very complex and comprehensive meta-analysis. One focused on type 2 diabetes. A1C is the main endpoint and outcome. The other one focused on HIT, health information technology, on CVD, causal factors for diabetes, and we use only diabetic patients in these trials. The impact evaluation designs that we focus on, you can follow that design flow. It was more or less what you would expect. We focus on randomized designs, and this is just a very diagrammatic and didactic description of the types of design. And we found that almost every one of them was represented in um, these two very large meta-analysis initially. Um, this is a little bit more of it. You have the lecture on that with you, and we can use it. I know you cannot see that well because it's too small, but I just wanted to show the graph, what the meta-analysis has shown. It's clearly uh, an effect. These are the average reduction A1C achieved by those in information technology. We've gone over thousands of papers. I don't want to go and describe that. There's a citation there, and I'm going to send this updated presentation to you. You can go to the citation, obtain all the information. But the impact was pretty significant, not only significant statistically, also clinically, very close to what you achieved through medication. Not as effective, but very close if you remember what A1C means. I don't want to go and do much about it at this point. I just wanted to show that's the first level of effort. It took us about two years to get it published, nearly 3 years. And these are some of the same effect. As you can see, we have A1C as the main outcome. There's an overall impact. There are two measures. One is a crude measure, the other, which is the reality. The other one is more adjusted for biases. And these types of meta-analysis, for those who curious about meta-analysis, check what the HG is. But it's very solid and robust type of statistic metric. And We also done the same for the CVD, very similar effect. And these tables summarize it. I'm not going to debate and go over it. That's not the main purpose of the presentation, but to want to show to you that these are not only statistically significant, but clinically impactful intervention. Parallel to that, we had many studies done by Dr. Kim and his research lab. In parallel, we coordinated a little bit, not much. It came almost by serendipity, but also we thought that was important early on. It brought them to work with us, and I'm involved in that too. Dr. Boren was also involved, and we pushing more in that direction to trying to understand how mobile phone-based intervention were doing their work, because the mobile phone, out of those HIT technologies we identified, were the most powerful. Mobile combined with what I call self-management, education, support, intervention. So Dr. Kim, there are many studies, there are about 4 published, but I'm highlighting one here. And you have the citation again, you're going to see that. They've done a review of many apps, features of these apps, blood glucose monitoring, diet management, physical exercise management, medication management. And they, if I could summarize their main finding, actually, one thing that caught my attention, that few apps address the following qualitative principle as expected by American Diabetic Association and many other diabetes technical and professional and health promotion groups. Problem solving, it was not part of that equation. Reducing risk and health coping, very important uh, domains of the self-management theory, and that's proven to work. In addition, I had another publication with that look into more of a policy issues, found some other problem with some of those HIT technology that we review. Thousands, we end up with a few, 30 in one study, I think 18 or 19 in the other, we did the meta-analysis. And Dr. Kim also reviewed a lot of apps and messaging that was associated with those apps. And then we found issues with validity and reliability, privacy and security, and more importantly, engagement of patients, reach, adaptability, things of that nature. So we concluded that there are issues with the internal validity, but what was more curious, because meta-analysis are so powerful for internal validity, uh, still missing a few elements in those clinical trials, but most of them are hitting the bullseyes in terms of finding an effect measure that's reliable and valid. I would say their validity overall is pretty good, but there are issues there too. However, we found issues related to reach, fidelity, and patient engagement that needed to be addressed by future research. And the last 2 points underscore to us about 2 years ago the need to implement the dissemination implementation research on HIT and type 2 diabetes. In the absence of a development in our own labs, mine or Dr. Kim, of our own app, even though it's something he is pursuing right now, I think, we needed to use what we had from the meta-analysis to try to do something about it. And that's what we did. And why we done that is because of this. And this is interesting because I found this wonderful publication by Dr. Ballas, Dr. Boren, that's our people from University of Missouri and HMI, that it takes about 17 years for research to reach practice. Only 18% of practitioner in administrator report using evidence-based practice. So it takes a long time for evidence-based practice to come to fruition, be utilized in the field. And great portion of that problem is attributed to lack of appropriate dissemination and implementation research that helps people to make that potentially effective or efficacious uh, intervention into a practical element. And this is a good example coming from Rothwell in this paper in 2005. If you have enough 100% effective and impactful intervention, if you look into adoption, training, fidelity, access, sustainability, assuming a 50% threshold, that's 0.5. What you get in the end is a 3% benefit. So that's pretty poor. And part of it is because this issue of adoption, training, fidelity, access, sustainability, that could be simplified into implementation, reach, and maintenance, in addition to adoption training. And that's exactly what the REAIM model does. So in a nutshell, dissemination, it's just the information sharing. Implementation is the intervention integration, pragmatic under usual conditions, relevant to stakeholder, and rigorous, meaning it's practical. So I could summarize DNI research or science is the systematic study of how evidence-based intervention, that means I have an efficacy that I can trust, the internal validity of that is decent, and some level of effectiveness, but not widespread evidence that actually is going to work in the real world. But if I take that evidence-based intervention, practice, and policy, and find a way to prove they're integrated into the healthcare and community settings, we will have an intervention that reach the level of impact that we all desire. So what we've done at that point, about a year and a half, 2 years ago, is to start another study we did, in which we use REAIM framework to evaluate internal and external validity of those interventions that we evaluated through the two very large meta-analysis, all published. And we contacted back every one of those investigators who published their randomized trials, trying to obtain more information because in the papers are not available. And I'll summarize this by saying to you, we applied totally the REAIM intervention model, which basically look into reach, effectiveness, adoption, implementation, maintenance. Reach being defined two ways. I'm going to the practical way. Who is intended to benefit, who actually participate or is exposed to the initiative. Effectiveness being in a pragmatic way, the most important benefit we are trying to achieve and what is the likelihood of negative outcomes. That's important too. Adoption, again, a pragmatic is where is the program applied and who applied it. So we had to obtain that information, the most of it through direct communication with the researcher because the manuscript themselves were not explaining, and contacting back those researchers did not get much more information because they have done this earlier and some of them have lost their record or the details and they couldn't explain the implementation. So implementation, how consistent was the program delivered? How much did it cost? Why did the results come about? Do you understand how they're operating? That's what I'm trying to do now with Dr. Kim's research around the apps, how they're actually operating, what are the domains they are hitting, things of that nature. Pragmatic use for technical definition of maintenance, when was the program operational and how long are the results sustained? And that's what we apply on those studies. And doing so, you can read this more carefully. The results we found 20 studies were reviewed that were focused on the apps, okay, and SMS. And the comprehensive of report of criteria was low in general for the REAIM criteria. Likewise, we found limited information, external validity indicator across adoption, implementation, maintenance. Well, these are top issues for dissemination implementation, adoption, implementation, and maintenance. Concluded that reporting gaps were found in internal validity, but more so in external validity in the current SMS and apps-based DSMES literature. Because most studies in this review are efficacy studies, the generalizability of the intervention could not be determined. Future research needed to adopt REAIM dimensions and blah, blah, blah. But the more important thing is that we could not find the so-called external validity that would allow those interventions, those apps, those mobile, those text message, whatever content material could actually be adopted widely. And we even negotiated with some of the investigators. We're still talking to them to see if they would like to continue doing follow-up. And this is part of the discussion I would like to leave for the end of our presentation. So you and I can have a discussion about that. Say, what can we do and ideas. So I would like to have ideas from all of you participate, how we can proceed and pursue this aim of expanding the so-called external validity and adoptability maintenance implementation of those interventions in large scale, basically scaling them up. So going back a little bit what the dissemination and implementation are, there are many, 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 many papers on that, but I found those easier to digest in simplified summaries. Dissemination, target distribution of information materials to public health or clinical audience. Implementation, the use of the what I call effective strategy to adopt and integrate evidence-based intervention and change practice patterns within specific settings. So it talks about the integration, it talks about intervention, it talks about practice, and it talks about setting in addition to the efficacy or effectiveness of the intervention. So the DNI research, actually, this is very similar to the classification that NIH is using recently, designed to prevent a disorder on the onset of an adverse health condition may intercede around the time of this event, may be continuous over a period of time, or may occur afterward. So bottom line is this research area has been explored very well in the past 10 years. But remember, when you talk about randomized clinical trial, we're talking about nearly 60 years of study design, starting in the 30s, actually way before, but really an organized, being highly published and things like that. Whereas this issue of dissemination implementation research started really in the 2000s, about 20 years ago, but really uh, took up, you know, took over, whatever we call it, in around 20, two 20,000, 2002, 2003, when I was at CDC, we had a very large uh, conference on the issue of dissemination and implementation. We brought a lot of researchers to Canada for a 3 days conference on this issue involving our colleagues from NIH to talk about it. So this is something new and very few are doing it. And we think, well, we found the clinical trial, it should work. Well, it works very well in perhaps in pharmaceutical, when dealing with a drug, it's a little bit easier. But here's different when we're talking about prevention and control efforts. It's a lot more difficult to do. So the goals of DNI represent distinct stage, aim to improve adoption, appropriate adaptation, delivery, and sustainment of the intervention. And a public health aims understand how 7 types of intervention can be delivered. And I'm using the word public health in a very general way here. It includes healthcare to some extent. Uh, if you are in Europe, public health is everything. Here, we separate the two camps, and it complicates a lot. It simplifies for didactic purpose, but it's not very smart. At any rate, we got programs, we got practice, we got principles, procedures, products, bills, policy. It applies to any one of those. And there are examples. This is a good paper that defines that 7 P's very well. Again, program, practice, principle, procedures, products, bills, and policies. Um, this is a good um, way to present the idea of dissemination and implementation research together with all the other types of studies that we all be involved. If you think about the traditional clinical trial, they will be more in this efficacy study area that you see here, the efficacy area, little square. Then you have the effectiveness studies, which are studied the same ways. And I'm going to show to you that dissemination implementation can be done, that type of research, together with an efficacy and effectiveness trials. It's called hybrid designs. We're going to go over that later. But bottom line is you can see the role of dissemination implementation research has gained momentum, especially after 2003, like I mentioned, because of the amount of knowledge we had already accumulated about efficacious and effective intervention, but still not making a difference on the incredible incidence and prevalence of diabetes in the past 20 years. So that's a focal area. Same can be said about cardiovascular in some areas like hypertension. And, there are many effective interventions that have not been generalizable because of this lack of exploration, how we do these things, how do we implement and package to be scalable. So then you have the issue of exploration, adoption, preparation, implementation, sustainment, and this model by Brown in this paper in 2017. And the critical question is that making a program work. It's not does the program work. We know it works, but in somewhat good condition, but making a program work in any condition, everywhere, anytime, and be scalable, that's the whole issue about dissemination and implementation research. A little bit more about the DNI trials. Attention to external validity, evidently, I'm beating about the bush, but I think it's important to kind of contrast that whereas external validity is the focus here, the efficacy effectiveness trials is internal validity. Okay, and we know the program delivery in practice and community setting here, we have a very specific ways and so-called efficacy and effectiveness trials to define what the universe of internal validity is. And good research, all of us should know that well, but it doesn't guarantee that's going to have an impact on a population level because of the DNI. I'm going to go over about those four phases of the implementation process: exploration, whether the service delivery system or community organizations find a particular intervention useful, given its outer context and inner context. So if somebody finds it useful and decides to adopt it, that's what we call exploration. Preparation is putting in place the collaboration policies, funding, support, and process needed across the multi-level alter and in the context to introduce the new intervention. When we talk to those researchers from those 21 uh, apps and mobile and text type of strategies that somewhat were working, they could not give us more information how they envisioned that collaboration, the policies, funding, support, and processes. There was a lot of information that they could not give us on that. And even something they should know better, that's implementation fidelity was missing in some of those things based on what they thought was the original design of the intervention. So support process, they are developed both within a host delivery system and affiliates to recruit, train, monitor, and supervise intervention. That fidelity, some people question, some people would say in some areas, and not all areas in so-called public health or intervention uh, evaluation, but in some areas of prevention evaluation, that fidelity should not be a focus because you need to have so much adaptability that you do not require fidelity. But that means every time you adapt, go off of the original intervention, you need to reevaluate the internal validity issues like you need to do another study again. And that's why the hybrid design, I'm going to mention it at the end, are very important because it allows us to see both at the same time. Sustainment, how host delivery systems and organizations maintain or extend the support of that intervention. So these are critical pieces. I'm going to skip that issue of process output. That's another way of looking. That's my old way of looking into evaluation. I wanted to throw in there. You can read it. And I'll bring to this nice uh, diagram by Rebin. It was published way back, actually, nearly 12 years ago, but it's very important during public health management and practice. I published a few papers that back in time. So you have the issue of diffusion. That's another concept that's imposed in that new model here. Dissemination, implementation, adoption, sustainability. And the fulcrum that holds everything together is effective implementation. The diffusion, dissemination, implementation continue. It's applied to an effective intervention. But this is a model that many people at the Centers for Disease Control now are looking seriously into health promotion and other strategies. But we haven't got to that discussion in relation to health information technology, especially apps and mobile have exploded in the past few years. Um, Out of that model, I singled out a few issues about design characteristics so we can see a little bit of differences between clinical effectiveness, which is a form of dissemination and implementation research versus, but it's not quite the what we want. You have comparative effectiveness still done through a clinical effectiveness trial kind of optic, but we talk more about implementation trials. Many times instead of DNI, they say implementation trial. So I found some general separation of the two based on the type of testing, the typical unit of randomization, typical unit of analysis, and the summative outcomes that we look at. So typical units of randomization, well, in a clinical trial, if it's a um, traditional clinical trial, is the patient, that's the unit randomization. If it is a cluster randomized design, a group randomized design, both patient and clinical units are unit of randomization, okay? Because you randomize in the clinical level, but you may have another randomization at internal level, or you just have it at a clinical level at the unit. However, in a typical traditional design of randomized trial, your unit of analysis is always the individual, the subject of your study, the patient. Whereas in an implementation trial, it can be and should be provider, clinical unit, or system. It's more general, trying to see how does it work? Does it work for the whole system? Does it get the whole population when I do my unit of analysis? Um, so summative of outcomes, health outcomes, process quality measures typically consider intermediate, and then you have cost. You can do that in a clinical effectiveness trial. However, in implementation, you focus on the issue of adoption. You focus on each of uptake of the clinical intervention. The process measures, quality measures typically are considered outcome as opposed to the biological endpoint that we care for in effectiveness trial. And then we have this very simple 2012. Again, it's been a while. It's 8 years ago. Um, Paper from Medcare that shows this very simple, you know, and then the diagram, but it shows that between effectiveness and implementation research, you can impose the so-called hybrid design. And I'm going to just give a little quick overview of the hybrid designs so we can have time for discussion. I want to do this more about short presentation with a lot of discussion. And the whole presentation has all the materials that describe in more detail technically each one of those studies, but I want to go over just for another 5 or maximum 10 minutes. So in here you can see that, let's say your traditional efficacy studies could be your pilot on a clinical trial level with apps, perhaps. That's your trial, that's your original trial. It's a small quality study, but very controlled. It's a traditional efficacy trial. It's efficacious. The outcome, if you change your A1C for diabetes, it's efficacious, show that efficacy of the change in A1C by that specific intervention. The effectiveness will be a little bit larger study, including a little bit more of perhaps more clinic, more patients, but also a little bit more variety in your intervention levels and what we call effectiveness, because you're actually applying in a real, uh, let's say, healthcare clinic, as opposed to that subset of the healthcare clinic that people are paid to be in a study or an efficacy trial or have incentives or all types, let's say, both patients and the people participate. You give authorship to the clinical folks, so they are authors and core investigators with you. So there's a lot, and you can control all the elements. Here, you still control some of the elements, but you have a real world situation. That's your effectiveness trial. And then you go to the hybrid design, and the implementation research is really the exploration of what happened once this is scaled to a level that never seen before in the real world, and you don't have control of all the elements of implementation. And then you need just to evaluate that elements of implementation. The hybrid design picks the middle of the effectiveness implementation, measure both effectiveness and implementation. And that's what I wanted to show to you. This is what we need to be going to, but can we do it? What should I do? And I'll give a little bit more the context that I want advice for all of you in this presentation. So in the end, what we want to achieve, what everybody wants, improved processes and outcomes. The outcome for efficacy and effectiveness, we want that. That's the biologic endpoint. That's the change in your health status of the patient. And also we want an outcomes for implementation research, which is adoption of with fidelity, is efficacy of the implementation, meaning not efficacy, efficiency of the implementation, and then adaptability that's maintained over time. That means you have longevity on that intervention and all the other elements that makes it sustainable, like the organizational support, the ethical, cultural, and in a big public health program, it would be like the contextual thing that makes a community adopt an intervention. It's like, if you can make the example in terms of maintenance and sustainability of intervention, if you're trying to develop an intervention for reducing gun-related death, accidental gun-related death, and your intervention is some form of proven scientifically gun control, and you go to county in northwest Missouri, and then you try to sell that idea, it's not going to work because everybody there is an NRA member. So that's a good example right there. That's about uh, feasibility of implementation, so to speak. So the hybrid design there are in this diagram, I could simplify them in hybrid type 1, type 2, type 3. And there's a good paper on that on Medcare that I mentioned before is also addressed that. And I will just go quickly on type 1, type 2, and type 3, and then we stop and I'll ask questions. So type 1, the primary focus still assessing clinical intervention effectiveness. Unit of randomization, still the clinic, the patient, or the clinic, if it's group randomized design is a clinical unit. Comparisons, usually placebo, treatment as usual, and competing treatment. All these are a combination of those. Sampling frames, you have patient, you have provider, limited restrictions, but some inclusion, all of some inclusion exclusion criteria. I've never seen one without one. Methods, primary and quantitative, summative, secondary and mixed method may be applied in a hybrid type. Qualitative processor and could also inform interpretation of primary aims and finding. But it's still pretty much a focus on assessing clinical intervention. And as a secondary objective is the collection of information implementation process. So it's never strong design. And we have plenty of examples. I could go on and on in the lecture, give example papers that trying to do that don't do well. Because once you focus on clinical intervention, you lose a lot on the so-called externality that we need. The type 2 is similar to the other one in terms of unit of randomization, but for the clinical effectiveness aspect, but because it's focused on both equally, both implementation and effectiveness, for the implementation, it need not to be, although maybe non-randomized, for example, case study can be used to do that. So usually what they do is they would have a traditional randomized design and subset a case study to do this testing for implementation strategy. Comparison clinical effectiveness, see type 1, which is the one before for the clinical effectiveness, but which is the same. You got placebo, you got the other treatment, standard treatment, so on and so forth. But for the implementation is case study. We'll do that. And I'll review that when we go to type 3, which is the next level. That's full on implementation. Sampling frames, there are differences, again, depending on if you're focused on the patient, on the provider, all in the same study. These are type 2 hybrid. Methods, primary aim, quantitative, summative. The secondary aim is mixed methods. You usually try and need to have a mixed method. Qualitative research becomes extremely important because it explains a lot what's going on. For instance, akin what Dr. Kim is doing right now with this qualitative type of quantitative methods applied to qualitative research and process oriented to trying to understand what's going on with that intervention to some extent. Measures, primary aim, patient symptoms and functioning for the primary aim. For the secondary aim is adoption fidelity. So that's a type 2. A type 3, you still have a primary focus. It's no longer, not still, you no longer focus on the effectiveness. You focus, that's your main objective, utility of an implementation. And secondary focus is assess clinical outcomes associated with implementation. Folks, I'm simplifying a lot of steps. This is my way of saying you may see something different, some other classification, and bear with me, the publications are there, you can read it. The unit of randomization, provider, clinical unit, facility system, it works for both aims, both primary and secondary aims. The comparisons always at a clinical level and facility and system levels, all these levels. Sample frame is always at the clinic level. In methods, it's a combination, but for primary aims, you're always going to have some quantitative, and then you still apply formative, summative, mixed method, because you had the process evaluation if you want to add together with the primary aim. And the secondary aim is a quantitative, summative of the efficacy of the trial. Measures adoption of clinical treatment and fidelity, and secondary patient symptoms, functioning, and service use. So it's not focused so much on the effectiveness of the trial, but it's more like complications, unexplained issues that happen in a study. I'm not going to talk about that because we've gone too long. We about 45 minutes. Where do I have a watch here? Yes, it's about 35 minutes of the presentation. So all I like to do now is to just open to a discussion. And the discussion is about our research on HIDR. For those who don't recall, HIDR is the Health Informatics um, and Diabetes Research group. That's our core for this large NIH grant we're part of for the past 5 years, well, 4 years going. And then we are going to go to the next phase now. And I needed to bring that presentation so you can tell me, well, we've done all, you help others to do this incredibly complex and powerful meta-analysis, two very large meta-analysis, this large uh, dissemination implementation research using a re-aim approach to go over the same studies used in other studies were added in the meta-analysis. And then you have all this body of research done by Dr. Kim that basically say, I don't understand exactly how these apps are working. So now I'm in a situation say, what do I do next with this issue? I know it works. We just don't know how it works, how we can explain it. I cannot replicate some of the apps. I don't have the expertise to do that. Maybe some of you do. Maybe make some suggestions. That's what I was hoping in this presentation and discussion. Or we could try again to connect with these people and see if they can allow us to do a more what I call type 3 hybrid design implementation and this dissemination implementation research using the apps brought to scale. So I want to know what's your ideas about that. And if you have questions about this dissemination implementation, there's more to the to this slides than I presented, and with the publications, well, not more actually. I only left at the adaptive design, but there's more in the publications that you have. You have a very good material to understand how these things work. It is a big piece of the research enterprise by NIH over the past 10 years. It has grown a lot. Many actually announcements are coming specifically on dissemination implementation research. And I know that's what next we need to go, not because there's funding for NIH, it's because we've done all this groundwork and these incredible researchers, all those thousands of trials review, have done the efficacy and effectiveness trials on the apps. But how do you go next? How do you bring it to scale? None of those mobile apps and text message approaches that we reviewed have been applied to scale, really large scale. We have not identified as of August last year, last time we communicated with one of them, and we checked each one of them. They have just done the trial, maybe going a few more weeks or month on that experiment in that clinical setting and stop it. So where do we go from here? So that's the discussion point I'd like to have with you. Um, how do I go about this? I'm going to stop sharing and go back to my image and ask you the questions. Can you hear me? Anybody? Any comments? Can you hear me? Diana, are you there? Hello?
We hear you. We hear you.
Well, maybe I went too fast on this and people didn't get.
No, sorry. Can you hear me now, Dr. Simoes?
Yeah, I can hear you.
Okay. If anyone has any chat, go ahead and unmute yourself. If you have any issues, just chat in the chat box and I will unmute you.
There is a comment by Karen Edison, hoping that the trust established between specialty teams and primary care provider now Show Me Echo program, longitudinal mentoring learning collaborative will help PCPs adopt new evidence-based findings earlier than 17 years. That's a good point, Karen. Loved it. You're right about that. The echo is an incredible idea. Actually, I don't even know how to conceptualize a dissemination implementation research around the echo. It's an interesting thing.
Well, it's a format where you can, if the researchers can ever agree on what really does work. It's a format where we can push it out and reinforce it and reinforce it and reinforce it, you know, and so it's a format where we can kind of ensure that adoption happens a little quicker, hopefully.
I hate it. That's it. Absolutely. I'm with you. Any other comments, folks, on this stage we are in our research? You know, those very large meta-analysis we've done, both on type 2 diabetes and cardiovascular risk factor for type 2 diabetes. And then we took all the apps and web-based and text message, especially apps, mobile apps with DSM, diabetes self-management, um, orientation, and look into their external validity and applicability to scale them up. And a lot of information is in there, a lot of the ideal settings that when people need to have were not deployed or not informed, and we can never scale that up based on the what is published. So we need to do better research on that. But I'm asking you now if you have any idea where we should go now. Should we try to develop our own apps, taking ideas from all the other apps we review, they are effective, efficacious, or should we just trying to again go back to those research and see if they agree to do a larger trial, scaling them up and doing a type 3 or type 2 hybrid dissemination implementation research. There are specific grants for that. This is a point I have a few months to make that decision. This is my first time I bring this up in this presentation, so you can inform me. You don't need to do that now. You can send it to email. But if we can have a discussion, I would love to hear where many of you are in terms of thinking where we need to go there.
Hi, Eduardo, this is Russ. So I'm new to your environment, so I may be off base, but we are working as I'm leaving KU on a R61, R33 mechanism for dissemination for aging on blood pressure control and dementia. And so it is kind of its primary outcomes are still at the patient level, but it is blurring into the implementation space of its hypothesis is that a lot of providers just don't confront their patients in primary care about blood pressure control. And so it's using it's basically setting up similar to a Coumadin clinic for managing anticoagulation, setting up the same thing for blood pressure control, and then working with the health systems at Kansas and then secondarily at Utah to actually just auto refer in the EMR and screen people to be measured at home by remote devices and have a pharmacist do the surveillance to see that their blood pressure is under control. And then the study will be measuring what impact that has on cognitive decline. But I think a lot of the initial phases will be, like you say, on implementation and dissemination. And I have not looked much in this diabetes space or published in it, but we did have some work by students in nutrition just beginning to look in the EMR at the rate at which people are making referrals to nutrition or to other people around diabetes management. So I was wondering, one question is, have you seen much done where people are looking at the data and finding that healthcare, while these apps exist, or you could try different drug therapy, adherence monitoring, what's happening in practice in large health systems, and could you design an intervention that kind of gets more direct to the patient to get them under control? Is that a place you might go with your work?
That's an interesting point. I'm glad you brought that up, Russ, because first of all, congrats on the other research on hypertension aging. Very interesting, and the way it's being disseminated, focus on implementation. I think it's exactly what we need. But what you mentioned in the end is very important. We found tons of publication which could not go into this strict criteria we use for the meta-analysis to be a purely randomized clinical trial. And therefore, most of the papers actually are what we call outcomes-based research. It'd be like secondary retrospective analysis of cohorts created in the health system and using big data and stuff like that. Maybe if I had if I had reviewed those for the dissemination implementation using a paper that we used the REAIM framework, we would have found more evidence of adoptability and adaptability. And that's something that's crossed my mind. Since you mentioned today, it's kind of made me think that maybe I need to look back in some of those recent publications, many of them which are not randomized trials, but give a little bit more of a flavor. How is it being implemented in the real world? Um, so I just wanted to make that point. And I think we need to maybe, maybe even don't follow this. What you say is that maybe we can use, oh my, you can use outcomes-based research to try to understand that. But that would be a little bit outside what I've been agreeing to do with
Well, I
some.
would just say that that R61 will be a randomized control study, but your other comments right on, because when I was at Vanderbilt, we didn't do RCTs. We would do at best a time series interrupted study just to see before we turned on the intervention across the house what happened. I was speaking to the fact that, when you look at it, everybody knows or it's known that maybe a nutrition consult will be good, or maybe this would be good. But when you look at the data, it's rarely done. And some of it could be because the counseling is done in the notes.
Mhm.
So I could imagine a direction you could go is trying to almost, if you had a phone app that was really effective, let's say, combined with follow-up by some type of nutritionist, pharmacist, I would wonder if there's, the ability of kind of driving the implementation through the EHR or through the health system, if that's an area that diabetes, funders are interested in. And you
Wow.
could either set it up as an RCT, you could do it as an RCT, or you could, like you were showing, there's all these different levels of implementation and dissemination research. You could do it at almost a higher level of trying it across different systems.
Yeah, we could try a type 2 hybrid trial, and it's highly fundable. Actually, NIH has actually mentioned, given this paper, they have this definition hybrid trial 1, 2, and 3 for people applying for their dissemination implementation grant, but it would fit perfectly into a trial type 2. That's a great idea, Ross. That's what I was looking for this conversation today with all of you. But it's amazing how many other interventions out there besides the apps for DSM, uh, are there. So is there? Yes, there's a lot there in hypertension and other chronic conditions that we're trying to change people's behavior to prevention control as opposed to just clinical treatment. Because the effectiveness and efficacy trials we historically know works very well for clinical treatment of diseases that does not include lifestyle modification, does not include changing the environment, changing the social context, or things of that nature. So drugs, yes, I don't really need much of high trial type 2 or 3, unless you really want to know why that Viagra patient died of a heart attack. True, in a Playboy Bunny Club in California. That's really about implementation dissemination. But most often, the clinical trials, effectiveness trials for drugs work very well in real life. But everything else doesn't, and we are believing it does. We are implementing those things. We don't know how they're actually working. So this is a great idea, Ross. I'd love to discuss with you a little bit more. But like you said the other day, I have the obligation to do that, but many people have so many other things they're doing. Say, should I go to this grant now to this other one? Because it takes about 3, 4, 5 months to write well a good grant. So you need to make decisions. I'm going ahead of time because I need to propose something a few months from today, how I'm going to go to the next cycle. We already submitted a renewal for this big grant because it's a center grant. But inside our own group, I have to convince our own course that this is a direction I need to go next. And that's what I was hoping to get from this conversation. I'm getting some from you, Ross, and I appreciate that. Come on, folks, more comments on this issue of dissemination implementation research. By the way, let's do a show of hands. Did everybody out there knew about this type of hybrid designs? Because when I show that to my students in epidemiology, they say, what? And how much we missed on all the so-called mixed methods. Europeans are way ahead of time on this. 30 years ago, I went to England and well, it's more than 30 years ago, Jesus Christ, 35 years ago. And and my teachers were teaching me how to do mixed methods research, and qualitative research was as important as quantitative. So they're way ahead of time. We start talking about those things 20 years ago, we start implementing through funding grants by NIH and CDC only about 10 years ago. And now we have specific lines of funding that says dissemination implementation research. You know, I think in over time, there will be a requirement for all effectiveness trials for most things to have a dissemination implementation research accompany it. Otherwise, it wouldn't be solid to actually offer to the patient, to the population in general. I'll make the exception to drugs. It works very well. You know, prescribing antibiotics did not need a hybrid 2 or hybrid 3 trial to make it work. But everything else, yes, it does. It does need that. And so, question to the folks, is it a valuable area that we need to get into in our University of Missouri School of Medicine research group, dissemination implementation research?
Absolutely.
Why should you create a center for dissemination implementation research 5 years ago? So they're always ahead of us, right? But they are my partners. And by the way, this group there is the group that used to be, we all used to be faculty together in the same department at St. Louis University. And they're all taken, 20-some people all at once from St. Louis University to WashU. This is an amazing feat. Nobody, press should have published that 15 years ago. It was a major coup. They brought them all together, 20-some people. Boom. But they have a center, and there are some of these people in the center are in the grant, and they help me with some of the discussions we have here, especially Ross Brownson, who has led this research tremendously, and Matt Kreuter. These are two good people who have studied this ad nauseum for many, many years. They're good friends too. So folks, I'm about time. I needed to be quick on that presentation, I knew. It's about 12:57. We still have 3 more minutes for any additional question, but anybody who feels they have an idea later on, send it to me through emails. We still have a few months to go and decide what the next 5 years of this grant research focus should be. We gave general ideas where we wanted to go, and we did mention this issue of dissemination implementation, but clearly it's not yet clear in our mind exactly what we need to do. So if anybody has additional ideas there, send it to me. Karen, in the new grant that we put together, we brought the ECHO program and telemedicine network into play. We made it
we've rebooted our diabetes echo, and we're starting a healthy lifestyles obesity echo that Amy Braddock, who's on this call, is going to serve on the hub specialty team. So, WashU might be ahead in some ways, but they're not ahead in real dissemination through our ECHO program. So keep that in mind and think about incorporating ECHO as you think about the research design.
Absolutely. If you read, I'll send you, it's not hard to read the stuff we put it together. You're going to see ECHO and telemedicine network is highlighted. And we have actually some resources for Min and I to work together and how to find evaluations for the ECHO and telehealth network. Okay. So folks, thank you for hanging there, getting a good discussion. Ross, thanks for your comments and everybody for participating. Sorry for being so quick in the presentation, but if I did a longer one, a little bit slower, you wouldn't have time to have this discussion, obtain this feedback that I think is invaluable. Thank you, folks. Have a good day. Thanks, Diana, for organizing this.
Thank you, Dr. Simoes.
Bye-bye.
Thank you.